And the clicker's just, does it still work?
Probably this one.
What's that? Can everybody hear me? Perfect. All right, so my name is Barfuma. I'm here to talk about new risk factors for spinal abscess. As I'm sure many people are aware, the classic triad of fever, back pain, and neurologic dysfunction is rarely present. In fact, it's less than 10% of patients. What you may not know is that 20% of patients or less actually have a history of intravenous drug abuse. Up to 20% of patients have no known risk factors. And to make matters even more complex, up to a third of patients are afebrile at presentation. That makes this pretty tough to figure out. In fact, in the last year and a half, I've actually seen 2 patients that were actively being followed by spine for their chronic back pain that ended up to be a vertebral osteo or a discitis. So who can you trust? I want to present a new trilogy or a new triad of risk factors to bring with you to the bedside so that you are less likely to miss this needle in the haystack diagnosis in the future. Part 1, the immunocompromised. But we're going to remix this a little bit. The first portion of this is people with end-stage anything. And you need to think broadly. End-stage renal disease. These patients are getting dialysis regularly. End-stage liver disease. Your alcoholics, your cirrhotics, your hepatitis patients, your end-stage lung patients, your COPDers who are on 5 or 10 milligrams of prednisone daily, or they're admitted regularly a few times a month and they are on superhuman doses of Solumedrol, or they're on these prolonged ridiculous tapers of 2-3 weeks. These people are immunosuppressed. Your oncology patients and your transplant patients obviously fall into this category, but also so do your malnourished. And by that I mean your alcoholics, your homeless patient, your frail elderly patients fall into this category. So that's the immunocompromised. Next, people who like to put things where they don't belong. This is your IV drug use patient. This is your patient who has recently been instrumented, and by that I mean a spinal procedure, even within the last few years. It doesn't need to be within the last few weeks. But also, think about all your patients with a port. Your chemo port, your hemodialysis port, your peritoneal dialysis port. You are playing Russian roulette, begging this patient to become bacteremic the more that they are accessed. We often see patients who have an indwelling Foley catheter. And I'm sure we all have thought of these patients as colonized and that we don't treat their UTI. I like to think of that as a reservoir of Staph aureus that is just waiting to seed this patient's spine. Next, the recurrently ill. And this is the most important portion of this trilogy, and we're going to talk about that a little bit more later on. But first, I have some friends I want you to meet. These are all real cases I've had over the last few years. This is Rodney. Rodney's an 85-year-old gentleman. He was actually admitted a couple of weeks ago for a UTI. He's brought in today because he's weak, and the family can't take care of him anymore. That UTI was secondary to Staph aureus. He's actually an end-stage renal disease who's on dialysis. Subsequently also found to have Staph aureus bacteremia at that admission. The inpatient team did a pretty good job. They did an echo, which was negative. They exchanged his dialysis port for good measure. Sent him home. He went home about a week ago. He comes back to us today. He was offered rehab at time of discharge, but subsequently refused. The family thought they could take care of him. and now they're bringing him back feeling a little bit remorseful. Needs to go to rehab. Rodney, what's going on today, bud? Why are you here? I'm weak. Need to go to rehab. Okay? Anything bothering you? Not really. My back hurts a little bit. When did that start? He was adamant it was from the hospital bed. I've been getting worse. I just don't feel well. I haven't been able to shake it off, but I just need to go to rehab. That's all he kept saying. He had a temp of 99.8 at triage. Stupidly, I had sent a set rate in the CRP. Actually, I saw this in preparation for this talk. Both over 100. I was fortunate enough to order the MRI, and the patient went to MRI before the hospitalist was able to come back and cancel it. At which point he had a T10, T11 discitis with osteo. What are his risk factors? End-stage renal disease, right? He's on dialysis. He's immunocompromised. He's constantly getting accessed. He was recurrently ill. He was Staph aureus bacteremic 2 weeks before. Meet Frank. Frank's a very healthy 80-year-old gentleman. Lives by himself. He's on a 10 milligram dose of a statin. He was painting his house the week before I saw him. His family lives down the street. They say he's sharp as a tack. I said, okay. They bring him in today because he's just not acting quite right. They subsequently go on to say that he had a prostate infection. He was treated with antibiotics. He finished the antibiotics last week, and they kind of wonder if it could be back. He had a 100.3 temp in triage. He had a little bit of CVA tenderness. He did have a greater than 100 WBCs in his UA, but also had a ton of blood. I scanned his belly thinking that if this is an infected kidney stone, this is something I have to go more towards the source control route and get this guy on the route to instrumentation. When in fact he had a psoas muscle abscess, subsequently had an MRI as an inpatient showing an osteomyelitis with discitis, and was also subsequently found to be Staph aureus bacteremic. What are his risk factors? None, really. You've got this vague history of maybe being infected recently. And that's really all he had to work with. Otherwise, not a whole lot here. And this is the hard stop in today's program. If you see someone who is recurrently ill, you need to expand your differential. And you need to consider other possibilities. And why do I say this? 35% of patients who are found to have an epidural abscess have had a prescription for antibiotics within the month. These people are pre-treated beforehand. Why else do we care about this? 2 out of 3 patients at time of presentation are bacteremic. That means they're sick, right? If you see someone who's bacteremic in the emergency department, they're probably pretty ill. You're probably paying more attention to their hypotension, their UTI, their rigors, and admitting them. And you're not necessarily caring so much. And what happens on the inpatient side? They end up staying in the hospital bed for 2 or 3 days. They say, oh, you had a UTI. They're discharged they're discharged with a week of Levaquin. And what happens? 2 weeks later, they come back to your departments and they see you. And what do they all say? Has anyone ever heard this before? My UTI is back. Right? This is exactly what happens. One of my favorite studies. Patients with Staph aureus bacteremia, and I keep going back to this because 70 to 90% of epidural abscesses are Staph or Strep. Staph aureus bacteremia, 12%, they did tag WBC studies on all patients with Staph aureus bacteremia, 12% vertebral osteo or epidural abscess. This isn't 12% of the positive results. This is 12% of all comers. To boot, in the same study, 60% of patients, 60% of all comers had a deep space infection. We're talking endocarditis, we're talking liver abscess, splenic abscess, things that were not previously thought to be there, all right? If people are recurrently ill, if you're looking back at the medical record and you see they were bacteremic within the last month or 2, you need to expand your differentials. Meet John. You all have a John in your department. John smokes like a fish. He drinks like a fish. And he smokes like a chimney and drinks like a fish. And he is homeless, right? You all have these people in your departments. He comes in one day, we give him his courtesy neb, we give him his courtesy tuna fish sandwich, and he has a seat. And in the morning, say, okay, John, you gotta go, let's get going, clean it up for the day crew. Except John's urinated on himself. And this is strange because John usually goes and pees in the corner or pees in the hallway. This is uncommon for John. And I go, John, what's going on here? What happened? I'm sorry, this has been going on a little bit more frequently. And you pause because you know that this is John's rap sheet for the last 3 to 5 days, right? COPD, COPD, back pain, COPD, COPD, back pain. You know when you see someone that has that one of your regulars that develops a new complaint, you know how this ends, right? And you can change COPD to homeless, to alcohol, to your chemo patient who's dehydrated. Anyone that's there regularly and now they get a new complaint, need to expand your differential. John's risk factors. Immunosuppressed. You pick your favorite one. He's an alcoholic. He's on superhuman doses of steroids. He's undomiciled. People who put things where they don't belong. He's probably constantly accessed. We're probably constantly doing lab draws on him. Meet Bobby. Bobby's in his 20s. I'm in triage one day, and Bobby comes in with back pain for the last 2 weeks. He felt 2 weeks ago. He wants to make sure he's okay. He felt 2 weeks ago. He said, okay, no fever, no chills, no neurologic dysfunction, no urinary dysfunction. Here's your discharge papers, right? And this is pretty close to the face I get. And he's smart. He then goes on to tell me that he had surgery about 4 months ago. Wants to make sure everything's okay. Refuses to leave without imaging. This is actually his image. And of course his hardware looks okay. But if you look way at the very top, you can see that, I believe that's T10, T11, greater than 50% erosion from his abscess. He's got multiple skip lesions. He's got osteo in his hardware. He's got osteo throughout his spine with multiple abscesses. Also failed to tell me about his IV drug abuse habit, which he had relapsed about a month ago and was scared to tell us that in triage. What are his risk factors? People putting things where they don't belong. He was recent hardware 4 months ago. Again, there's multiple case studies that show that this does not need to be within the month. This can actually be within a year or two to get infected hardware. Even though peak incidence is at about a month. And of course his IV drug habit. Meet Claire. Claire's actually his significant other. Claire comes in. She was actively seeing spine for the last 3 months. She had seen spine multiple times. Claire has had worsening back pain. She's got a fever. She's got intermittent urinary dysfunction. Now she's got subjective symptoms in her leg. This is a shoo-in, right? This is a no-brainer. And she's an IV drug user as well. This is not a one that you're going to miss. The interesting part, and why I bring this up, is what happens 6.5 weeks later. She was off antibiotics for 5 days. She was out of the hospital for 5 days. She comes back and she says, I was feeling good for the last month or two. My pain was gone. About 3 days ago, my pain came back. This morning, I felt feverish. I will be damned if she did not have another one in the department, right? She was off antibiotics for 5 days when she had developed a recurrence. What are her risk factors? People who put things where they don't belong. We talked about the IV drug habit, and then she was instrumented as well during the course of her hospitalization. But she was recurrently ill. She had a prior osteo and abscess. And this I want to be very clear about. What I'm about to say next is my opinion. However, I firmly believe that having a prior episode of osteomyelitis, of vertebral osteo or an epidural abscess will be a huge risk factor going forward. And this is why I say this. When you look at the orthopedic literature, total knee replacements that get infected, within 5 years, you have a 20% recurrence rate despite a 2-step revision. And these patients are watched like a hawk. It's often the same bug, but these patients are watched like a hawk by ortho. You take a look at these patients with endocarditis. One episode of endocarditis, 400-fold more likely to have a recurrence than the general population is to have one episode. So what we see here is that one episode of a deep-seated infection begets another. And in fact, there's only been one paper that has looked at this, 20 to 30% recurrence within, I believe it's 1 or 2 years. And I have to ask, who is watching these patients? And so I end with a plea. I'm asking you, please, 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 be vigilant. You cannot go on autopilot. We have seen this time and time again, where it's been up to us to care for the immunocompromised, where it's been up to us to care for the recurrently ill, and for patients who like to put things where they don't belong. But please, 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 you must be vigilant. You cannot go on autopilot, because you can trust no one. Thank you.
Yeah. We'll take a little break. Don't forget to tweet. Got the contest. Thanks, Pat.